So, welcome to today's episode of the Normalized Surrogacy podcast by Surrogacy Mentor. I'm your host, Carrie Flamer Powell, experienced gestational surrogate, surrogacy agency founder, and owner of Surrogacy Mentor and Modern Parent Mentor, where our aim is a safe, ethical, and enjoyable surrogacy journey for all. Today, I am again joined by one of our favorite guests, Dr. Susanna Park of San Diego Fertility Center. Welcome, Dr. Park.
Thank you. Nice to be here.
Nice to see you again, as always. And today we are going to be talking about egg donor and gestational carrier screening and medication protocol. We've had some questions come in from listeners of the podcast that we're going to be asking you. So before we get into that, I want to, again, give a little bio of Dr. Park and all of her amazing accomplishments. So Dr. Susanna Park is a trailblazing fertility physician whose journey has led her from the prestigious halls of Columbia University in New York City to the forefront of reproductive medicine at the San Diego Fertility Center. With a decade of experience at Columbia University, Dr. Park honed her skills in infertility treatment before embarking on a new chapter in San Diego in 2012. There, she seamlessly blends her extensive expertise with a deeply personalized approach to patient care, striving to optimize success for each individual. Her dedication and innovation have earned her the esteemed title of Top Fertility Doctor from San Diego Magazine, an incredible 6 times. No, maybe it's more now. Yeah. This recognition holds special significance as it's given by local physicians who trust her with the well-being of their patients and very own family members. Born in Seoul, South Korea, and raised in Buenos Aires, Argentina, Dr. Park's multicultural upbringing equips her to provide compassionate care in English, Korean, and Spanish, fostering strong connections with diverse communities. Wow. So welcome again, Dr. Park.
Oh, thank you for the kind introduction, Carrie.
All right. So we have some questions coming in from our listeners, and they would love to know some information about egg donor and gestational carrier screening, as well as medication. And I love when we get to do educational posts like this because we in the industry are it's so common to us and we know all these answers automatically, but we forget that surrogacy is still very much something that the general public is being educated about, right? Like from the basic stuff that we don't consider basic, but we need to continually educate and help people understand all of the different basics. So let's jump in and let's start with egg donors. And let's talk about the screening criteria for an egg donor from the clinic perspective.
So one of the first things is her age, right? So as egg donors get older, right, because men create new sperm all the time. We are born with our eggs. So as we get older, our eggs age with us. So that means a decrease in quantity and quality. So in general, when you use an egg donor, especially if it's somebody you don't know, we try to use an egg donor who will give you the peak egg quality. And that's generally women in their 20s. Okay. Mm-hmm. Now, many times you'll see, and we as well will have some egg donors in our database who maybe are 30, 31. And the reason why she's still there is because despite her age, she's still having great egg response. Many times we'll have people come to us with a family member or friend who so generously offer to donate, but she's 34, perhaps she's 38. And the issue with that is we're fine with it, but it's a matter of education that as she gets older, you will likely get less quantity of eggs and less quality. So when we're talking about the ideal egg donor, age-wise, the 20s would be ideal. And then there are certain egg tests that she will do to make sure, right? So that's her egg test, the AMH, anti-Mullerian hormone, a follicle-stimulating hormone, and an ultrasound for something called antral follicle. And what the antral follicles are is every month our body naturally activates a group of eggs. And if you don't take IVF drugs of that group of eggs, which is your antral follicle, your body naturally picks one to grow big and ovulate. And all the other eggs just die off. Such a waste. But if that woman takes the IVF drugs, those other eggs don't die off and they will grow big along with the one egg that was intended to grow big and ovulate.
Wow. So even though I say this is like common for us in the industry, I actually didn't know that the IVF drugs cause those others to not die off. I had no idea that was part of it. Wow.
No. So what that means is a common misconception is two very common misconceptions. Number one, a lot of people say to me, okay, can I get like 48 eggs from my donor? My friend did. I tell them, well, it depends on the antral follicle count of your donor for that month, because we always do a baseline antral follicle count. And if it's 24, then I'm not expecting 48, I'm expecting 24. If it's 32, then I'm expecting 32. The second common misconception is a lot of, especially the egg donors, think, well, my gosh, I'm donating and now you're taking all my eggs. Not true. These antral follicles are dying off anyway. You're going to lose them anyway. We're just trying to save them from death so we can make use of them, but they are going to be gone anyway. This is not your future egg supply.
That's really important, I think, for people to understand. That's so fascinating. Okay, got that. Okay, so in addition to that, what are you looking for on the clinic side for screening an egg donor?
Yes. So medical issues, right? So she has to be in good health. And it's okay if she's had surgery, but it can't be anything major that we think will impact her health or put her at risk during the donation. What medications are you taking? She cannot be smoking, absolutely no drug use. And her family history is very important. So all the donors undergo screening by genetic counselor who will take a family tree and figure out, I think you have a number of risk factors that I think will eliminate you as a donor. Okay. In addition, egg donors also do screening for various mutations of the DNA. We all have mutations in our DNA. It is part of being human. You're not looking for a donor with no mutations. What you're looking for is a donor who has mutations that are different from that of the sperm source. Okay?
Oh, okay, got it. So that both carrying it.
Different mutations.
Got it. Okay, wow.
And then in addition, there's a psychological aspect to this. So all donors, as well as intended parents, undergo psychological evaluation to make sure that she fully understands what will happen. She understands her role in the process, etc.
Okay, perfect. So it's very different from surrogate screening.
Right.
Completely different thing.
Because the genetics of the donor is very important. And many times people will say, well, gosh, her uncle has a family history of being alcoholic. And there are certain things in family history that are absolutely no. And then there's certain things that are, well, it's really up to you. And one of the things I tell people is if that makes you pause, maybe you look at your own family history and if you in the sperm source, right? And if there is a strong family history of alcoholism, maybe that's not the best donor for you. Right.
Oh, sure. Yeah, that makes sense. So what would you say on this topic of screening would be the one or two most common reasons an egg donor would not qualify?
Oh, for sure. Her own medical history, her family history, for sure. So, well, because we just happen to have our own egg donor database, but we work with a lot of private egg donor agencies. And when we screen our own egg donors, less than 10% actually make it into our database because a lot of them, just by interviewing them from the first interview, we can already tell that just the medical history that we glean from them is a red flag.
Got it. Okay. So obviously egg donors, you're looking so much at their health, not only their health at the time of donation, but their health history and their family's health history. And genetics is huge, right? Because this is going to be this is biologically going to be part of that child. So Okay. So anything else you wanted to add about egg donors before we switch over to surrogate in terms of screening?
Not in terms of screening, but one of the things I do want to mention is many times when people want to use a family member or friend, with which we are fully supportive, people realize they have to take on this burden of the screening. Who's going to schedule the screening? Who's going to make sure she does this test or that test? And that is usually taken care of by the agency or the clinic has its own egg donor database by the egg donor team at the clinic. But if you're using a family member or friend, the intended parents need to know they have to assume that responsibility, which can become a lot of work. It ebbs and flows, right? In the screening process, there's just so many things on the to-do list you have to check off, and it can get a bit overwhelming. But keep in mind that once you get all that work done up front, it will make the rest of the process easier. If you have an agency, the agency will do all that work for you.
Got it. That makes a lot of sense. Yes. Okay, great. And so, on the topic of screening, let's switch to gestational carriers. So, this is a common misconception as myself, a former surrogate. It's still very much assumed by the general public that a surrogate's genetics or egg are going to be used, right? And it's actually not true. And so, let's talk about what are we looking for when we're screening a gestational carrier.
Right, correct. So, back in the day, the egg donor was also the carrier, and that is not allowed anymore, right? So, correct. So, the surrogate's genetics are much less important. It starts the same surrogate's medical history, surgery, making sure that she hasn't had major surgery that, again, will increase her risk when she is pregnant. And for a surrogate, unlike an egg donor, her pregnancy history is really important, right?
Right.
So the American Society of Reproductive Medicine, which is our national organization, has put forth some very strong guidelines, which is 5 or less deliveries, 3 or less C-sections, right? So sometimes if I get a surrogate and it's a family member or friend, and wow, she's been pregnant 6 times, so this will be the 7th time she's going to deliver, I tell the intended parents, hold up, we've got some risk issues we need to discuss here. Okay.
Right.
Or if she's had 4 C-sections and now this is going to be her 5th, that really puts her at risk when she's pregnant. So her pregnancy history is really, really important in the process. Okay.
Yeah.
And then separate from that, of course, are what medications is she taking for what medical conditions. Her family history is not as important because, again, we're not using her genetics, but we still take it because what if I hear, well, my grandmother had breast cancer, my mom had breast cancer, my sister had breast cancer. Then I say, wait a minute, right? Have you had a workup for breast cancer? You have a very strong family history of this. And it may then alter the protocol I use. I may try to move towards a less hormonal, more natural protocol. So her history absolutely is very important.
Right. Okay.
And then physical exams. So surrogates must come in for physical evaluation, okay, as do the egg donors as well. But for the surrogate, what we're really focusing on is her weight. Weight is very important. The more obese a surrogate is, the less likely that the transfer will work, and the higher the pregnancy complications of diabetes and high blood pressure and stillbirth and C-section. So weight is very important. Full physical exam. And again, really focusing on that uterus. Is that uterus healthy enough to carry this pregnancy?
Right. Okay. Got it.
And then, like the surrogate, the donor also needs psychological evaluation, again, just to make sure she understands the process and she understands her role in this process.
Super important for psychological evaluation and consultation to do an evaluation, make sure everything is healthy, everyone's healthy, but also that the surrogate's questions and the egg donor's questions, right, are answered about what to expect.
Absolutely. Absolutely. And to understand who has parental rights, who does not, how much contact do we want, that all of that should be in writing.
Right. Okay. Great. And so switching back to egg donors, now that we, let's say, evaluated the egg donor, she looks great. She's come in for her evaluation. Everything's great. So now we're going to talk about when she is ready to start a medication protocol. What does that involve? What does that look like?
Yes. So her medications are not pills. They are all needles. They're about 1 centimeter short. We call it subcutaneous, meaning below the skin. So she injects in the fat layer under her skin. And it sounds so scary. And gosh, for these donors, when it's the first time they donate, it is very scary. Probably about the third day of the injections, you become a pro at this.
Yeah.
Okay. So you inject every day, about 9 to 12 days. So about a week and a half. And during that time, you need ultrasounds, and the ultrasounds are all vaginal. So transvaginal ultrasounds and blood tests about 4 or 5 times in that week and a half span. So that's a lot, right?
Mhm.
And a lot of them cluster at the end. So, for example, she'll do her baseline transvaginal ultrasound and blood test. In a few days will go by, she's injecting at home and nobody's monitoring her. But probably after a few days of meds, she'll get monitored with ultrasound and blood work. Then 2 days later, more vaginal ultrasound and blood work. 2 days after that. And then at the end, it can become every day until she hits the target that we want. And the targets are, we want a follicle diameter, a handful of them, to be close to 20 millimeters, thereabout.
Mhm.
And she may need perhaps one more day more, or perhaps she's ready. But that's why we watch so vigilantly at the end, because we want to make sure we find the perfect timing. Now, we don't miss it, but also we don't want to trigger too early.
Right. And so I'll admit that as a surrogacy specialist, I am much less educated about egg donation and egg donor cycles. But correct me if I'm wrong, during this 9 to 12 days you mentioned of medications, is it true that what you're hoping to accomplish during this time is to mature and essentially grow her egg into viable eggs?
Correct. So at the baseline, we do the transvaginal ultrasound to look at the antral follicles to see, all right, what did your body activate this month? And whatever that number is, we tweak the dose of the medicine based on that number. And the hope is that whatever that number is to get them all to grow. So as we're watching her, we're saying, oh, yeah, look at this. Oh, beautiful. They're responding so beautifully. Well, perhaps it's, oh, whoa, she's over responding. Let's scale back on the dose of the medication. And this is why she gets monitored so closely. Yeah.
Got it. Yeah. So that's why it's so important for them to be coming in and seeing you and looking at, because day to day things can change quite drastically, right?
They can. And many of our donors, of course, if they use our egg donors, they live in San Diego, but many of our donors don't live in San Diego because we work with a lot of private egg donor agencies. So what happens in that case is she monitors in her hometown, but I manage her from San Diego. So I will tell her on this day, go in for your transvaginal ultrasound and blood work. We wait for the results from the clinic. And then we email her and we say, okay, please change your medications as follows, and please go back on such and such date. So this just keeps happening for about a week. And then after a week, she flies to San Diego to do perhaps 1, maybe 2 more days of injections. And then she will be ready for the retrieval. So this can be done with a donor that does not live here in San Diego.
Right. And I know that we'll talk about this with surrogates as well, but that's remote monitoring where you as the physician and the fertility clinic are managing the cycle, but someone else in another location is following your orders, your medical orders, and doing the actual procedures of monitoring of that donor or surrogate. So that's pretty cool. So you're still managing it. The cycle is still under your direction. But she can live where she lives and still be a part of the cycle, which is kind of great. So can we talk about then what happens when she's got all of these beautifully matured eggs ready for retrieval, how does that process work?
So one of the biggest, and rightfully so, fears of egg donation is hyperstimulation syndrome. Okay, ovarian hyperstimulation syndrome, which we call an OHSS. So back in the day when I started, which was 20 years ago, I've been doing this 20 years, I always had a patient in the hospital with OHSS. It was so commonplace. Yeah. Because back then we only had one trigger and we didn't know so much about, we always wanted IVF cycles to work. So we didn't really know how to change the triggers or how to dilute them, etc. Well, thankfully, a lot has advanced in the 20 years. And so now we have such an array of triggers. We have, of course, our traditional super strong triggers, which I still use in women who don't have a great egg supply and they're making perhaps 4, 5, 8, all the way to our weakest trigger. Okay. Now, the difference is the strongest trigger has the higher risk of ovarian hyperstimulation syndrome. The weakest trigger has the lowest risk of ovarian hyperstimulation syndrome. But again, you don't use the strongest trigger in women at risk for hyperstimulation syndrome. So if I'm giving my patient who's got 3 eggs the strongest trigger, she is not going to develop hyperstimulation syndrome because OHSS depends on the number of eggs you get. So with the donors, because I'm expecting a lot of eggs, she is at risk for ovarian hyperstimulation syndrome. So I tend to use the weakest trigger, which is called pure Lupron. Problem with pure Lupron is it works most of the time, not all the time. Right. So if you do enough cycles, there will be a cycle where you will say, oh my gosh, what happened? Right. Unfortunately, that happens not often, but it does happen. So there are certain criteria you need to think about. So again, most of our donors, we do pure Lupron trigger. But for example, let's say she has a history of irregular cycles. Pure Lupron trigger tends not to work so well in women with irregular cycles. So in that case, I'll do a little bit of a combo. I'll do pure Lupron predominantly, just a touch of the strong trigger, just a tiny amount, just to make sure there's enough trigger medicine on board. Okay? But trigger is so important because it does 2 things. Number 1, this is what pulls the eggs out of the follicle. So when she has her ultrasounds, you see these black follicles growing, these black circles. They are follicles. And the hope is that there is a microscopic egg in each follicle. Right. So the trigger pulls the egg off of the follicle. And number 2, the trigger is what makes the eggs mature, because you can only put sperm into an egg that is mature. So the trigger is incredibly important.
Got it. Okay. So I knew the first part because I actually I used Clomid to have my daughter. And then they did, I believe it was called Avridel.
Avridel. Yeah, it's good.
Yeah. This is like 13 years ago. 14 years ago. So yes, I remember that it was to release the egg. I did not know that it also matures the egg.
Correct.
Cool.
Really cool. And so the egg donors will absolutely feel some bloating and sharp stabbing pain. Absolutely. But then she will notice after a few days, I'm finally turning the corner. Whereas in the past, it was a week, if not longer, of not being well.
Oh, got it. Okay. And then once the eggs are triggered, then she's back at your clinic for a procedure, correct?
Correct. So the timing of that procedure is very important. And clinics vary, but generally clinics will retrieve the eggs about 35 to 36 hours. Some clinics do 34 to 34, 35, 36 hours after taking the trigger. So it is so imperative, and we emphasize this to all our donors and all our patients. When your clinic tells you this is a time you must trigger, you cannot be late for that trigger. It is so important that you set 2, 3, 4 alarm clocks to get that trigger in at the time you were told to do so.
Right.
Okay. So once that trigger is done, the egg donor presents to the clinic, and most clinics have their own outpatient operating room. Most clinics will put a patient to sleep. Some people use a nurse anesthetist. We use an anesthesiologist, which is an anesthesia physician. And I often get this question, is it general anesthesia? The answer is yes, it is general anesthesia, but you're not intubated unless you're very overweight. You're breathing on your own. You are hooked up to a breathing machine. It's called the LMA, laryngeal mask, that goes in the back of your throat just to keep your tongue forward so that the flow of oxygen is very free. But you are usually 99% of the time you're not intubated, but you are asleep. Okay.
All right.
And the eggs are removed through the vagina. There is no abdominal incision. Now, have been times, and generally not an egg donor, when I'll have a patient where her ovaries way high up, and then that I will retrieve abdominally. But even then, it's not cutting the abdomen. It's like you poke a hole through the abdomen and get the eggs out. But that's rare. 99.999% retrievals are done vaginally. Okay. So there's no scar. Okay.
Right.
The duration of the surgery is dependent upon how many eggs one gets. So most donors will take me about 20 to 30 minutes. In contrast to a woman in whom I'm expecting 3 eggs, I'm done in 5 minutes.
Right. Okay. Got it. Wow. And so you're literally surgically removing the mature released eggs, and that's what is then used to create the embryos.
Correct.
Cool. Okay. Awesome. And so as you're talking, I'm thinking it's important for people who are listening, women who are listening specifically that are interested in becoming egg donors and or surrogate, to understand the importance of timing and following the specific medication protocols and all the appointments, and how important it is to understand why. You said less than 10% of egg donors make it through. I'd say less than 5% of our gestational carrier applicants make it through. And sometimes, I'm sure you see this on your end as well, sometimes it's not because of the medical records. It's because there has been, unfortunately, a history of them not following medical advice or not having proper prenatal care. And we then have to deduce that they won't also follow all of the very specific instructions that come with surrogacy and egg donation. And so it's super important that people understand that timing of all of these things are so critical and are part of the application and approval process, right?
100% true. Yeah.
Yeah, absolutely. Okay. So switching gears to surrogate. We talked about egg donors and how that works. So surrogate medications, how is that different? What are we looking for surrogate?
It's so different. So it starts off much easier. So the surrogates need 2 hormones, estrogen and progesterone. Now, I'm talking about a medicated cycle, which most fertility clinics still use, but the unmedicated, more natural protocol is gaining more popularity, and I'm a big fan of it. But generally in surrogates, I do use medicated cycles. So in a medicated cycle, you're basically creating the environment for this embryo to implant, which involves 2 hormones, estrogen and progesterone. So estrogen comes in various forms. There are tablets by mouth, tablets by the vagina, patches that you apply to your skin, or intramuscular shots. That's the big needles in your butt.
Oh, I remember.
Well, progesterone comes in many forms as well, but the progesterone also is oral. There's progesterone gel, vaginal injections, but most clinics, because they want to ensure adequate absorption, most clinics will use progesterone injection. But again, if your clinic uses something different, it's not wrong, but the majority of clinics for surrogates will use progesterone injections, big shots in the butt.
Yeah.
Okay? So it starts off easy with just estrogen. We use oral estrogen tablets. So it starts off with estrogen tablet by mouth. Now, if I get a surrogate and she had a beautiful cycle somewhere else and she used estrogen injections out the gate, I'm going to follow the same protocol that worked for her in the past, because why recreate the wheel, right?
Sure. Yeah.
Assuming she has not done surrogacy in the past, or perhaps she did and they also used oral tablets. Generally, we will use oral estrogen tablets.
Okay.
The goal of this is to make her endometrium lining nice and thick. Again, we don't need her eggs. We're not focused on her ovaries. It's just the uterus. And you generally want a lining. Some clinics use 7 millimeters thick. Some use 8, which is what we use, and some use 9. So there's a thickness factor. And number 2, there's a pattern. You want what's called triple layer pattern, which is 3 white lines. So thickness, quantity, and quality of the pattern. Okay. And usually it takes about a week and a half, maybe 2 weeks of estrogen tablets to reach this milestone. Once you've hit that, you continue the estrogen, but now you add the progesterone injections.
Mhm.
So the progesterone is so important because it takes that thick lining and converts it to a secretory lining, meaning, hey, I'm getting ready to accept an embryo here. So going back to the timing, once you do the progesterone injections, usually the transfer will be 5 or 6 days after you've started that progesterone injection. And your clinic will let you know which day it is. So again, timing is super important. So if the surrogate does not live in San Diego, as most of our surrogates don't, she monitors in her hometown. We're managing her from here. But then once I see, oh, your lining looks beautiful, start the progesterone injection. This is the day of your transfer. So right then and there, we know, okay, the projected day of the transfer absolutely is correct. Let's make sure we've got a flight for her, hotels booked, everything.
Right. And so, again, for people listening, with the egg donors, we were trying to get those eggs matured and beautiful and ready to retrieve. With surrogates, the goal of these medications, correct me if I'm wrong, is to get a nice, beautiful endometrial lining for that embryo to snuggle into and hopefully implant into, right?
Correct.
So when surrogates talk about having a fluffy lining, they're talking about a nice, filled up, beautiful endometrial lining, which, again, correct me if I'm wrong here, but that's what your body naturally does during a menstrual cycle. That if you aren't pregnant at the end of that process in your menstrual cycle, you then have a period, right?
That's exactly right. Yep.
Okay, so we're getting a fluffy, comfy place for this embryo to land. So once we've achieved that with our medications, then what happens for the surrogate?
So in contrast to that of the egg donor, the surrogate's procedure, which is an embryo transfer, is so easy, wide awake. It takes like 10 minutes. Okay.
Mhm.
So if the surrogate is traveling, she must arrive the day before the transfer. She stays at a hotel. And the next day, I perform the transfer. And again, she can come by herself because there's no anesthesia. So nobody needs to really take care of her. After the transfer, she goes back to the hotel to rest because that is the day of implantation. And then the next day, she flies out. Okay. So when she comes in for the transfer, she's wide awake. And again, these surrogates, most of them have had vaginal deliveries. Sometimes we do get surrogates who only had C-sections, but the majority of them have had vaginal deliveries. So when you deliver vaginally, the opening to the uterus is never the way it was before you had vaginal deliveries. The opening is so easy to negotiate. Okay. So the transfers of the catheter slide in so easily. It's so painless. And it's really cool because we have ultrasounds on at the same time. And so the surrogate can actually see the embryo transfer occurring. And intended parents, of course, are always welcome to fly here for the transfer, be present in the room. But most of our intended parents do not fly here for the transfer because a lot of them live very far away.
Sure.
So they are welcome to be present by phone, or if not, we'll make sure it gets recorded so that the surrogate can then share the transfer with the intended parents.
I love that. That's very, I can attest as someone who's gone through an embryo transfer, it is definitely painless. The worst part is having to drink all of that water. Why do you make us do that, Dr. Park?
I know. So in our clinic, we transfer either abdominal ultrasound or vaginal. And when you fill that bladder, most women, not all, but most women have a uterus that leans towards the front. We call it anteverted. When you fill that bladder, because the bladder is in front of the uterus, when the bladder fills up, that uterus is pushed back so that it becomes a straight shot versus a curve.
Mhm.
And so we like having that full bladder because then it gives me the freedom to not only to have the catheter going easily, but sometimes I'll look abdominal. I'm like, oh, it looks so beautiful. Or sometimes I look abdominally and I'll say, oh gosh, it's kind of hard to see this uterus. And then I'll do it vaginally. And having that full bladder makes visibility much easier on an abdominal ultrasound.
Got it. So it's for a good purpose. It's just you feel like you're going to pee yourself for like 3 minutes.
No, I know. And it's okay if you pee. I've been peed on before. It's just the way it works. It's okay.
Yes, it's all part of it.
Yep.
And so to give a little bit of a visual for people who haven't been through this, you are actually putting the embryo into a catheter, right?
Yeah.
And like literally this tiny little microscopic embryo is is it a flexible catheter or what's happening with this little embryo?
Yep. It's a very smooth, flexible catheter. So you can't see the embryo. It's surrounded by air bubbles. And then we see the catheter going into the uterus under ultrasound guidance. And when the catheter is in the right place, we hit the plunger. So what you see is this little white thing go flying. And white is the air bubble because air bubbles shine white on an ultrasound machine. And it is assumed that the embryo is inside that air bubble because you cannot see an embryo without a microscope.
Right. Okay. I've heard a fertility doctor describe it as a poppy seed landing in peanut butter.
Oh, that's a great analogy.
Because surrogates are like, well, if I stand up, is it going to fall out? And they're like, no, it's literally like putting a poppy seed into peanut butter. It's like sticky in there, right?
Yep. In New York, we used to say, it's like being in the middle of Central Park, right? It's not easy to find the exit, right? It's unless you don't park really well, right? You get so confused and turned around, right? You're like in the middle of this lush environment, and then either you will stick or you will not stick.
Yeah. Right. Got it. Okay. So it's super quick, in and out. And then how long after that would you know if a surrogate's actually pregnant?
So the clinics vary, but most clinics will do a blood test. And again, if the surrogate doesn't live in San Diego, she does it in her hometown. About 10 to 12 days after the transfer through a blood test, you measure a hormone called beta HCG. And this is the hormone that's secreted once the embryo implants in the uterus. This hormone will be secreted, and this is what you're measuring in the blood.
Got it. Okay. Awesome. So I love the explanation for people to understand like what surrogates and egg donors have to go through to get to the point of embryo creation and pregnancy. Is there anything that you want our listeners to know about any of these processes that you feel maybe the general public should know?
Yes. So I know that many people, everybody has had a different fertility journey. And some people have tried with their own eggs or own uterus, and it hasn't worked. And that's where they're at this point. And some people have never tried, and this is just the journey that they have chosen. But as much as I know we talk about it, just seems like such the perfect recipe, right? Like, of course, everything will turn out just perfectly and fine. And as much as we would love that to be the case, I just want everybody to understand that this is biology. And sometimes despite our best efforts, Mother Nature just wreaks havoc with us. So for example, let's say your donor is ready to start, everything is in place, and she comes in to do her baseline ultrasound, and I see this big cyst on her ovary that wasn't there before. And I'm looking at it like, oh, why is this here? And then I measure the hormones, and it's secreting estrogen, which means it's hormonally active, right?
Okay.
That means she's not suitable to start. And as disappointing as that is, because, right, as the intended parent, you think in your mind, all right, let's see, she's going to start her meds. Retrieval will be this day. Embryos will be created in this day. And then we can do transfer in this month. unfortunately, sometimes things just don't work out as planned, which is so frustrating.
Yeah.
And then we have to push things back a month and then maybe another month and then, right. And so people understandably get so frustrated. The same thing with surrogates. I have surrogates that come in, they do their in-person evaluation. They look beautiful. The uterus looks great. We're ready to start the transfer. She takes her medicine. She's so compliant. And I'm looking at her lining. Why is her lining not growing? Or it's growing, but why is there not the pattern? And I finagle this, I finagle that. And I'm like, this looks terrible. Right.
Mhm.
And as hard as it is, I will cancel because I'd rather cancel and not waste the embryo than just move forward and cross my fingers that everything will be okay. And that is so frustrating. So for intended parents, this is unfortunately a journey and there will be ups and downs in the process. This is my only advice to you is partner with agencies, with clinics that you know will literally walk with you on this journey because it really is a journey with many sides and twists and turns. At the end, you will get to the end, but you will have these tangential experiences that unfortunately we wish you didn't, but you will. And of course, everybody has a friend who had this like perfect journey, of course, of course, but most people experience some kind of bump along the way. So just be prepared for that.
I love that. Yes. And it's so true. That's why we call it a journey. There's not a better word for it. There's ups and downs, and it's hard to explain to people that you've had your fertility journey, most likely, and that's had many ups and downs. And now you're embarking on a surrogacy journey or egg donation journey, and it's going to have its own process and its own surprises. And it doesn't seem fair. It really doesn't, but it's worth it. Right. I just so appreciate you again joining us to help educate people about egg donation and surrogacy. And I always learn something new, and I did again this time. So thank you for your time and your expertise. We so appreciate you.
Oh, you're so welcome. It was so much fun as always talking with you, Carrie. I really enjoy it. Thank you.
Thank you. And that brings us to the end of this episode of the Normalized Surrogacy podcast by Surrogacy Mentor. I want to again thank Dr. Park of San Diego Fertility Center. We will be linking to the San Diego Fertility Center's website for this episode, so be sure to check them out and all the great work that they're doing. Don't forget to also check us out at surrogacymentor.com if you're interested in knowing whether surrogacy might be right for you. Subscribe to our podcast to learn more about gestational surrogacy and how to have a safe, ethical, and enjoyable journey. Talk to you next time.